So I think we shall make a start. I see Jenny's here. So thank you everyone for joining us in a lecture series that celebrates MAHSC honorary clinical chairs in Greater Manchester, where we get a chance to hear about their professional and personal journeys, clinical and research areas, and plans for the future. And there shall be an opportunity to ask any questions you may have following the end of the lecture. So MAHSC honorary clinical chairs are awarded on an annual basis by the University of Manchester's Faculty of Biology, Medicine and Health Promotions Committee. And they're awarded to people across Greater Manchester who've made a major contribution to their clinical speciality, including excellence in research and education. So there are now 86 MAHSC honorary clinical chairs, and we'll be hearing from 3 of them today. We have a very busy agenda, so we need to all be mindful of time, and hopefully we'll have a chance for some questions following each lecture. So I'll now hand over to Professor Jenny Myers, who will introduce our first speaker.
Hi, well, good afternoon, everybody, and thank you for joining. I'm Jenny Myers. I'm one of the academics within the University of Manchester and Manchester Foundation Trust, and an obstetrician by background. And it's my great pleasure to introduce Rohna Kearney today, who is a consultant gynaecologist and subspecialist in urogynecology at St Mary's Hospital, where she's been based since 2014. She has been an honorary senior lecturer at the university, obviously recently fabulously promoted, and currently also serves as Deputy Medical Director for St Mary's Managed Clinical Service. She qualified with honours from the National University of Ireland and trained across Ireland, England and even the University of Michigan. And completed her subspecialty training in urogynecology at UCL before taking her first consultant post in Cambridge. And over the course of her career, Rohna has really established herself nationally and internationally as a leader in pelvic floor health. She's served on several committees and is a RCOG on the RCOG Scientific Advisory Committee as well. She's done lots of fabulous high quality research. I'm sure she's going to tell us about some of that today, and highlights being the co-chief investigator of the NIHR funded TOPSY trial, which I'm sure she'll be talking about today, which has won several awards, and also ongoing work around pelvic floor injury and pelvic floor care. Beyond her academic achievements, Rohna's also given time as a trustee of the charity Birth Aid, supporting surgical camps in Uganda, and travelling to Nepal as well to continue similar work. So I think we'll all agree Rohna's accomplished an enormous amount during her career and dedicated her career to improving the lives of women, and it's a real privilege and honour to be able to introduce her for this lecture today.
Thank you very much, Jenny, for a very kind introduction. I'm just going to make sure I have this on the correct mode. Let me know. Yes, is everybody able to see? Good. So today I'm going to talk about pelvic floor disorders and probing the research gap. My research journey began as an SHO in the Coombe Hospital in Dublin in 1997. And at that time, as an SHO, the midwives didn't repair any of the perineums after delivery. So all the perineal repairs were done by SHOs. And being the only SHO at a time on call with over 9,000 deliveries, I spent a lot of time looking at the vagina and perineum after vaginal delivery and wondering how it recovered. The man on the right there is Professor Michael Turner, who was master at the time that I was appointed, and he was very encouraging of all junior doctors to research and publish. And then to the left is Professor Chris Fitzpatrick, who was the director of the Continence Promotion Unit that I worked in the Coombe. And he taught me an awful lot about looking after women with urinary incontinence and prolapse, and he was also instrumental in encouraging me to pursue a research fellowship in the US. In 2001, I went to Ann Arbor, and at that time Professor John Delancey was making a name for himself as a pelvic floor anatomist, and he'd been awarded NIH funding to look at MRIs of the pelvic floor in women after childbirth. And when I arrived, his research team had recruited 240 women and obtained the MRI images. And this was 80 women who hadn't had any children, 80 women who'd had a first child and had developed new onset stress urinary incontinence, and 80 women who had a first child without developing any symptoms. And I spent a lot of time in a dark room back in the days where you had MRI films and you had to put them up on the light board to actually see, looking at the pelvic floor, and under his tuition and guidance, in particular scrutinizing the levator ani muscles. And what you can see in these images is the urethra, the vagina, and the rectum. And on either side, you can see the levator ani muscles coming up and attaching into the pubic bone. And over time, I began to see that some levator ani muscles looked different in some women. And what we could see was that some women had what appeared to be abnormalities of the levator ani muscles. And if you look at this image here, you will see that on the patient's right, she's a normal muscle coming up into the pubic bone. But on the patient's left, that muscle looks much diminished, and there's a gap in the muscle, and the vagina is spilling out to the side. In this image here, you can see there's a significant loss of the muscle, and the vagina is spilling out to touch the obturator internus on either side. And we began to identify that these were defects in the levator ani muscle. And the research that we found was that we couldn't see any abnormalities in the levator ani muscle in the women who hadn't given birth to children. But 20% of the women who had given birth had a defect or an abnormality in the levator ani muscle. And over time, we were able to apply a scoring system to determine whether these were major or minor injuries to the levator ani muscle. So I spent time in Ann Arbor looking at the delivery data of the women who were recruited for the study. And what we found was that women who delivered by forceps had a 14.7-fold increased odds ratio of having a major defect of the levator ani. And women who also sustained an obstetric anal sphincter injury had an 8-fold increase in the odds ratio of having a defect in the levator ani. So it was clear that forceps delivery had a major role to play in levator ani injury. And when I returned to Dublin in 2002, I returned to the National Maternity Hospital in Holles Street, and I was interested in understanding a bit more about forceps and why it was associated with such a high rate of levator ani injury. And with the support of Professors Colmar Hurley and Declan Keane, I obtained funding and approval to recruit 2 groups of women after forceps delivery. The first group was women who had a forceps delivery, usually because of fetal distress with a very short second stage. And the second group was women who had a forceps delivery for a prolonged second stage. And within the 2 groups, you can see there was a significant difference in the second stage length, with a mean second stage length of 25 minutes in the first group and a mean second stage length of 136 minutes in the second group. And what we found was a high rate of forceps delivery, a high rate of levator ani injury with forceps delivery in both groups. And you can see that with the image on the right, the figure showing the dark black indicating a major levator ani defect. And what we found was that 42% of women who had a forceps for a short second stage with fetal distress had a major levator ani defect, compared to 63% of women who had a prolonged second stage. So there clearly was an issue with the forceps itself being associated with significant risk of levator ani injury, but the length of the second stage was also a determining factor. When I was in Michigan, recruited women for another NIH-funded grant looking at the occurrence of levator ani injury in women with and without prolapse. And after I left, the results of that work showed that women who have pelvic organ prolapse were much more likely to have levator ani injury than matched controls who didn't have any prolapse. And it's now become accepted that levator ani injury is that anatomic injury that occurs to the pelvic floor muscles that most strongly correlates with the development of prolapse in later life. I moved to Manchester in 2014, and Manchester had a long history of obstetric pelvic floor injury research. And Tony Smith, who was here when I moved to Manchester, had done some research with Ruth Allen, Gordon Hosker, and David Worrell, which was published in 1990. And they recruited women during pregnancy and performed EMG of the pelvic floor muscles, which showed reinnervation in 80% of women after vaginal delivery. And reinnervation is considered a marker for nerve injury. They also noticed that more severe injury was seen in long second stage and with larger babies. Interestingly, their research didn't show a correlation between forceps and nerve injury. So I just want to talk about some work that we've been recently doing in Manchester, and that is looking at an imaging technique called MR neurography and evaluating if we could see the pudendal nerves in women after childbirth with MR neurography. So Dr. Joe Sentence and Dr. Emily Carter helped with this research and recruited 5 nulliparous women and 20 primiparous women who had sustained an anal sphincter injury at vaginal delivery, and working with Dr. Raja Shankar from radiology and physicists from the University of Manchester using the 3T MR scanner in the university, managed to develop a protocol to visualize the pudendal nerve and its branches. And what you can see in these images here is the pudendal nerve at Alcock's Canal and coming from the lumbar sacral plexus down through the canal, through the greater and lesser foramens, and branching off into the perineal, the inferior rectal, and the dorsal clitoral nerve. And this research has shown quite a high instance of abnormal signaling that we can see with MR neurography, using both water ideal techniques and diffusion weighted imaging. And what you can see in the top image on the left is the perineal nerve showing increased signaling, and the diffusion weighted imaging also picks this up, which strongly correlates with a neuropathy. It's probably more obvious in the image down below it. And we found actually 17 of 19 participants did demonstrate enhanced signaling with reciprocal changes in one of the branches of the pudendal nerve. Now, this high rate probably reflects the fact that all of these women had an anal sphincter injury, which we know is a marker of more trauma during childbirth. Emily Carter is now doing research looking in more detail at the risk of women developing anal incontinence after childbirth and how they make decisions about how they wish to deliver for their second baby and what the risks around that are. And as part of this, she has done a systematic review looking at the risks of developing anal incontinence if women deliver by vaginal birth or cesarean section after previous obstetric anal sphincter injury. And the literature systematic review really revealed the significant evidence gaps we have in this area. There doesn't appear to be an increased odds ratio of a woman developing anal incontinence, whether she gives vaginal birth or cesarean section after obstetric anal sphincter injury. However, there's a lot of confounders in this data, in that women who have more severe symptoms were more likely to have a cesarean section than a vaginal delivery for their second birth. When she looked at the group who had a subsequent birth compared to the group without a subsequent birth, there seemed to be no difference in the development of anal incontinence. So this raises important questions about what is the quality of information we have to counsel women, and what type of information can we give women for them to make a clinically informed decision about how to give birth. And it's clear that there's a lot further information that is needed, and Emily's research is going to look at trying to establish some more evidence around this question. The second area I've been interested in researching is how can we support women to self-manage their pelvic floor symptoms. And my first consultant post in Cambridge, it was Amanda Khan, who was the divisional director at the time, who encouraged me to apply to the Health Foundation for funding. And as part of that, I recruited Claire Brown, who's on the right, to deliver a program for women who were using vaginal pessaries to manage pelvic organ prolapse symptoms, to see if we could teach them to manage the pessary themselves so that they didn't have to come to clinic every 6 months to have the pessary changed. And we published in a quality improvement journal this quality improvement piece of work showing it was feasible to run a self-management program. But it's very difficult to change practice in the NHS without establishing a strong evidence base. And after an unsuccessful application for an RFPV bid, I joined with Carol Bouge from the University of Stirling at the time and Suzanne Hagan from Glasgow Caledonian University to apply to the NIHR HTA programme to get funding to do a randomised control trial where we actually tested the intervention of self-management of vaginal pessary versus clinic-based care for the management of pelvic organ prolapse symptoms. And we recruited 340 women across 21 UK centres between 2018 and 2020. And at baseline, both groups, self-management and clinic-based care, were very similar with a mean age of 63 years. And what we found at 18 months was there was no significant difference in the prolapse-specific quality of life between the women who self-managed and the women who were seen every 6 months in clinics across the country. We did find, however, that the women who self-managed had a lower incident complications. In particular, were less likely to complain of difficulty emptying the bladder, difficulty emptying the bowel, or difficulty having sex. And they were also less troubled by complications due to the pessary falling out. So what we showed was that in 18 months, a significantly lower incident of pessary complications in the self-management group compared to the clinic-based group. And when we tested whether this was cost effective, we found there was 81% probability of it being cost effective when compared to clinic-based care. We then got further funding to extend the outcome data to 4 years. And similarly, at 4 years, we found no difference in the prolapse-specific quality of life. And at 4 years, there was quite a bit of crossover between self-management and clinic-based care. Some of that was contributed to by the COVID pandemic, where obviously women were unable to access appointments to have their pessary changed. So many women chose to self-manage. And then some women in the self-management actually reverted back to clinic-based care. But looking at the per protocol or the intention to treat versus what women did, we still found no difference in the prolapse-specific quality of life. There was lower incidence of complications in the self-managed group at 4 years, but this was not clinically significant, and that was affected quite a bit by crossover. However, it was still found to have a very high probability of cost effectiveness. So self-management has been established as being safe for women who are using pessaries for prolapse who wish to, and it's also been established that it's much more cost effective for the NHS than clinic-based care. And on the back of that initial research, Lucy Dwyer has now completed a PhD at the University of Manchester, looking at the factors which affect willingness to self-manage a pessary for pelvic organ prolapse. She has done quite a bit of creative research as part of this, and she asked some women to make an identity box to understand what pessary management and prolapse meant to them. The image on the left is one of those identity boxes. And then Lucy worked with an artist to develop some artwork representing those identity boxes. And the image we can see on the right is one of those artworks. And it was my first exposure to creative research within urogynecology, but it was very powerful looking at these images and understanding the impact both prolapse symptoms, pessary management, and positive treatment had on women and their lives. Lucy also co-developed strategies with women to support self-management, and you can see here she has identified several strategies with women with lived experience of prolapse management that she can then research to see how we can support self-management more positively. And these include supporting women to overcome perceived and actual physical barriers ensuring women have necessary knowledge and understanding, maximising social support for pessary-using women, ensuring they have ongoing access to pessary services, considering emotional barriers to self-management, and boosting perceived self-efficacy, and reframing pessary self-management as a positive option. So I think the future is bright in that within St Mary's we have massive opportunities to reduce the impact of pelvic floor disorders on women's life. We can harness the strengths both at St Mary's, across MFT and the University of Manchester and other research partners to try and close some of these research and evidence gaps in pelvic floor disorders. We can promote prevention, optimise treatment, reduce disease burden, and increase education and self-management. And I'm very excited about what we can do in this space in the coming years. I'd like to end my talk by thanking the people who really made my professional research journey happen. And the first of those that I work with in the Warrell unit in Manchester. They were very welcoming when I arrived in 2014 and have encouraged every step of the way. And all of this research has involved a lot of teamwork. So I would like to thank all my colleagues in the Warrell unit. And finally, there's some other important people that I do need to thank. I need to thank my husband, Raj, who joined me on my research journey when we met in 2001 in Cambridge, and who has followed me to Manchester and has supported me every step of the way. And when we were in Cambridge, we were joined by two other people, Ailish and Una, and they also came with us to Manchester and have become Mancunians, but have now left Manchester to pursue their own exciting life journeys. So I want to thank them for all the joy and support and inspiration they have brought to my professional and personal life. So thank you very much.
Oh, Ben's going to come in. Fantastic.
Sorry. No, go ahead, Jenny, please.
No. I was just going to say, congratulations, Rohna. Fantastic. That was great to hear.
Thank you, Jenny.
Wonderful and lovely photos there at the end. We do have a couple of minutes for questions if anyone would like to ask a question of Professor Kearney. We have a Q&A function and a chat, or if you'd just like to raise a hand, we can enable your microphone and camera if you'd like to come in. Fiona, go ahead.
It was wonderful to listen to that overview. It's not my field of work, but it is clear how much you have steered and navigated over time. So my question is, and so congratulations on your chair. My question is, what would you advise yourself now if starting out again? What would be your top?
Yeah, I think a lot of my research, because I wasn't an academic as such, a lot of my research was somewhat opportunistic in that I found as time went on, I became more interested in researching the questions women asked me in clinic that I wasn't comfortable with the answer I was able to give, because I didn't feel that the evidence was there to support me giving a really concrete answer, or their questions caused me concern as to whether what information was out there was actually accurate and what level of evidence it was based on. So very often it was somewhat opportunistic in that perhaps certain areas of funding were looked for and I thought I could do that. I think if I was starting out again, I think I would probably have found one particular area. As a non-academic, you have somewhat less research time. I would have found one particular area that I had really wanted to focus on. But I do find myself constantly being drawn back to the obstetric-related pelvic floor injury and what we can do to prevent, treat, and bring a bit more attention to that. And the MR neurography research project started from a conversation that I had with a radiologist who works in Manchester Performance Sports Centre, and he was talking about, if a footballer has an injury or complains of a pain of a perineum, they get an MR neurography and they get this and that, and then we think if a woman has a vaginal delivery and has anal urinary incontinence, they don't get anywhere near that level of investigation. Why is that? So that's why we decided to see if we could actually learn a bit more about nerve injury after childbirth.
Fantastic, thank you.
Any further questions, anyone?